And I understand that the patient is a 70-year-old female, and according to some doctors, she had colonoscopy 3 years ago, and they detected only diverticular and no polyps. And she doesn't have any symptom now, but she's willing to have a screening colonoscopy. And first, I must explain that I usually use intermediate length scope. This is very long, but in Japan, we usually use intermediate length scope that is 135 centimeters in length. I seldom use this long scope for only obese person or very fatty person. Yes, and for very tall person or very obese person. And you may know that we use Lucera system, Lucera 200 series. You in Europe use Extra system and 100 series are used, but in Japan we use 200 series with magnification. But now you don't have magnification. You have near focus, but I'll try. So would you put some jelly on the scope? And can I have the gauze to hold the scope? And I usually have the screen in front of me here, not here, but today I have the screen here, opposite side. So anyway, let's start. So can I have it a little bit higher? Yeah. Although I'm rather short, but I prefer higher table. A little bit more. Okay, that's fine. Thank you.
Чи може
And
оператор показати руки Хіроші Кашида, як він працює, техніка?
is there any question? And
Asking about to show your hands moving.
yes, maybe the camera should be behind me, not in front of me, to show the procedure better. So I don't try to inflate too much here. So I'm trying not to inflate too much here. And now we're having CO2. So CO2 is a lot better than room air. And I have short fingers, so I do use up-down angle, but I seldom use right and left angle. My fingers are too short to move right and left angles, so I often use rotation, clockwise and counterclockwise rotation. And I try not to push too much during the insertion. And somebody talked about it before, but in Japan we usually use Buscopan. We inject the Buscopan just before the intubation. Maybe more than 80% of cases we use Buscopan from the beginning. Buscopan is useful not only for the detection of polyps, but also for the intubation too. So now I think the tip of the scope is in the sigmoid colon, and maybe you have identified some diverticula. So you must be careful not to insert just into the diverticula. Yeah, this is not the true lumen. This is a diverticulum. So you must be careful not to push against the diverticulum. And so maybe they haven't injected the Buscopan in this case. So the colon looks a little bit spastic. You can't identify the lumen very well, but I'm trying not to inflate too much CO2.
We can make the injection of Buscopan if you want to.
Oh, yes, I think that would be better to inject. A small amount is enough. So I usually inject only uh, 1/4 of the ampoule. That accounts for 2.5 milligram or 5 milligram. I'm not sure, but small amount is enough. And I usually don't sedate the patient, so I often ask the patient to change the position. But today the patient is sedated. Oh, she's coughing. What's the problem? So if I feel it is difficult to go beyond the sigmoid distending junction, I often change the position to the superimposition or even right decubitus position as necessary. But today I'm trying not to change the position of the patient during intubation. So if the patient is sedated too much, it will be difficult to change the position. I think now the tip of the scope is near the splenic flexure, and I feel that the sigmoid column is a little bit elongated, but I'm trying to shorten the column as much as possible. Can you see my right hand? I'm pulling back the scope as much as possible. And some people don't care about forming the loop, but I try not to form a loop from the beginning. And you should resolve the loop as soon as possible. So our technique in Japan is called shortening and straightening technique for intubation. Now I think the tip of the scope is in the transverse column, but as you can see, when I push, the tip of the scope goes back. It's called a paradoxical movement. In this case, maybe you have to try another thing. Maybe often the time I change the position of the patient. Can I change to the supine position? Maybe. And with this scope, you have the variable stiffness too. Oh, so the position of the scope is not very good. It's now I see. So the trolley is opposite side, so it's a little bit complicated for me. I usually have the trolley in front of me, but now you can see some part of the scope is twisted and lying over the patient. So it can be a little bit difficult situation. And now I'm going to stiffen the scope. At the splenic flexure, I often use this technique too, but still you can see the paradoxical movement. In that case, maybe I can try right decubitus position or hand pressure. Maybe I'll try right decubitus. But it's a little bit complicated. Sorry. So be careful. No. Right decubitus will be better. Right side, on the right side. Yes, but be careful. No. Change the position. Before that, wait a minute. Before that, you should move the legs. Uh, yeah, very complicated. And wait a minute. Wait a minute. So uh, you should move the leg here first, and bend the knees, and move. No, no, no. On the I said on the right side. Right side. Yes. Yes. So and bend the knees. Bend the knees. Bend the knee. And can you see the patient is rather obese? And when the patient is obese, you can use this technique. Now, can you see it's very easy to go forward on the right decubitus position. And sometimes even I use prone position for very obese patients. Lie on the belly. So maybe from the beginning, I ask the patient to lie on his or her belly, and it will be easier for the intubation. Oh, no need for that. And the scope is a little bit complicated now. So maybe I should turn the patient back to the supine position if I can do that. Now, maybe we are near to the hepatic flexure. So can you make it a supine position on her back? But maybe, yeah, first, yeah, that's right. And can you move the, yes, that's better. That's better. But, and you should return the rigidity to the normal. So stiffness to the normal. Oh. Now, I think we are near the hepatic flexure. And pull back a little bit to see the ascending column. Yeah. As I said before, the position of the trolley is not very good for me, and the scope is too long. Well, again, there is some paradoxical movement. When I push, I cannot proceed. So maybe the column is a little bit elongated. I try to straighten and shorten it as much as possible. Suck the air, and yeah, it's 80 centimeters from the anus. When the colon is straight enough, the distance from the anal verge to the sigmoid descending junction is 25 to 30 centimeters, and the distance to the splenic flexure is about 40 centimeters, and hepatic flexure may be 60 to 70 centimeters. So would you change the patient position on her left side? Oh, so it's rather difficult to change position when the patient is sedated. So Still, I feel some resistance. The sigmoid colon can be elongated very easily, so maybe I need a hand pressure, maybe.
Hand pressure.
Yeah, wait a minute, wait a minute. Yeah. Oh, very big belly. So would you hold the belly like this? I should have started with the prone position. Prone position can make it very easy. I'm Now I'm looking for the ascending column. I push a little bit, but now I'm pulling back a little bit until I see the lumen. I push again. Clockwise rotation and up angle is very important. And pull back a little bit, pull back until I see the ascending column. I'm still pulling back. I'm still pulling back. I'm still pulling back. And now it's better. In order to advance into the ascending column, the column should be straight enough. More on the right side. Yeah, now I can see the ascending column and maybe ileocecal valve. And I'm sucking air and okay, release the hand. And if you cannot see the cecum well, maybe you can change the position of the patient again. So this is the ileocecal valve, but it might be a little bit difficult to enter into the terminal ileum. So in Japan, we usually change the position of the patient to the supine after intubating to the after reaching to the cecum. So can I change again to the supine on her back? During the observation, we usually have the patient on his or her back. Yeah.
Good enough for you?
Maybe it's good. And sometimes I try on the right side too. And can I have the water jet? Yes. And washing off still residue and bubbles are very important. Why continue? Washing and sucking residue is very important. But maybe have you put some simeticon to the water? Maybe not. We always ask the patient when they take purgative. We ask the patients to take a small amount of simeticon too. So for preparation of the bowel, we ask the patients to take maybe 10 milliliter or 20 to take per os during the preparation of the bowel. And we also put some simeticon to the water. You use water jet, we put some simeticon to the tank. So it is very useful for dissolving the bubbles. Now you can see the orifice of the appendix. So it is definitely thickened. So even without intubating into the terminal ileum, if you find the orifice of the appendix, the colonoscopy is complete. But without looking at the orifice of the appendix or terminal ileum, you should not finish your procedure. Sometimes you might make mistakes. So even if you think you have reached to the cecum, maybe it can be hepatic flexure or in the middle part of the transverse colon. So you must be very careful. Anyway, so let's go back. Do you hear me? Do you have any questions?
Yes, we hear you. Do you use in your routine practice?
No reaction from the floor.
Do you use in your routine practice a split dose of PEG? No, only 1 day bowel preparation.
Thank you. Do, can you hear me? Do you have any questions? I can't hear you. Do they have us on screen?
Yes, you're here.
What about
Hiroshi,
the
one question.
image? Do they have the image
about
too?
bowel preparation. Do you use a split dose of polyethylene glycol in your practice, in your routine practice?
Another question, Chris Mulder here. Another question is, it depends also how to prepare if you see a patient in the morning or late in the afternoon. So if the patient is coming later in the day, we always use split dosing. Then in the Netherlands, in the obese population with diverticular disease, we sometimes use also Dulcolax or some other things in day -3, day -2 to have already more emptying of the colon. Otherwise, in our experience, it doesn't work very good. If we have patients who are difficult to clean, we prepare them, let's say, the day before at home. We try to see them at the end of the morning. If they're not clean enough, we clean them with a nasogastric tube still for 2-3 hours in the unit and do the colonoscope at the end of the day. That's maybe a remark.
So, are you talking about the preparation?
Yes.
Can I talk about it a little bit?
Yes.
Yeah, in Japan, our basic rule is the same day dose, same day preparation is the basic. But in our university, we started the colonoscopy examination in the morning, so we ask the patients to have split dose the night before and the day of the examination. But generally speaking, in Japan, the same day dose is the basic. So we don't give the purgative the day before the examination, but on the same day of the examination. And we usually give only 2 liters, not 4 liters, for preparation. But we give the patient the night before a small amount of pico sulfate or some other laxatives beforehand.
Oh, thank you. The next question, in what percent of the patient do you use the sedation?
It depends on the clinic, but maybe in average, maybe 30% of the cases are sedated, 70% without sedation. And I usually prefer petidine and a smaller amount of midazolam than propofol. Propofol can be too deep for sedation.
А запитайте, будь ласка, чи вони роблять ESD під седацією? В яких випадках ESD роблять під седацією?
Do you perform ESD procedures with sedation or without sedation?
Almost always with sedation, but usually awake sedation with, as I said, petidine and midazolam or diazepam. Just a small amount. So the patient are usually a little bit awake, at least for colorectal ESD. So for upper GI ESD, we need to sedate the patients deeper than colorectal ESD.
What do you think about routine?
Tell me please, when you use the simeticone to prepare the bowel, 1 day before procedure or 2 days before procedure?
On the day of the procedure, in the morning of the procedure, maybe the patients take purgatives 200 milliliters each time, maybe 15 minutes apart. And for the last dose of 200 milliliters, we put simeticone into the purgative. So simeticone is very useful to prevent the bubbles formed. I don't recognize any polyps so far. Have you? Maybe not. Oh, we have run out of CO2. No?
Just stop it. The question is, do you use a routine retroflexion in cecum and in rectum?
Not routinely. Even in the rectum, I don't retroflex the scope, even in the rectum. But sometimes, yes.
Thank you.
But inflating and deflating air is more important than retroflex. Any other questions? I don't want to be very quiet, but there's nothing to explain. And some people prefer to use cap but during the intubation and observation too, but I don't use them routinely. But I put a short tapered cap every time for colorectal ESD. Tapered cap, but I don't routinely use any cap for the observation. Have you detected any polyps so far? No, I hope not. Now it's about 40 centimeters from the anus. It must be descending colon, and we are approaching to the sigmoid colon. So 3 years ago, she had colonoscopy and nothing more than diverticular. So I think nothing was overlooked during the last colonoscopy. Did you do that? Last colonoscopy? Not you. Maybe. So talking about diverticular, in Western countries, maybe diverticular are mainly located in the left side colon, distal colon. But in Asian countries, uh, they are often found in the proximal colon. So there are some differences about the distribution of diverticular. Maybe a racial difference or the difference of the food, maybe.
How do you find the bowel preparation in this case?
Not bad. Maybe we don't routinely use the Boston scale, but maybe Boston scale 2 second.
In this case, we use same-day preparation.
Same day preparation. Yeah, I think same day preparation is better than split dose. So split dose is better than day before menu, day before dosage, but same day dose is better than split dose, I think.
If patient goes to afternoon colonoscopy.
That's right.
In Japan, you usually use this type of
PEG, PEG solution, Niflec, or yeah, I think you have a newer one. I forgot the name. Moviprep, maybe.
Moviprep?
Moviprep. Moviprep is also very popular in Japan too. Yeah, I think Moviprep is sold by Takeda company in Russia and
In
maybe
Ukraine
in
also?
Ukraine also,
Yeah.
but not in Japan. So now we have reached to the rectum now. I don't see anything unusual, but which is NBI? This one?
Yes.
This one? So some people say NBI is better for detecting adenomas, but I don't use it all the time. I sometimes switch on the NBI, but I don't use it for detection. Oh, so this will be the end of the procedure.
Yes.
Is it okay? Can I finish now?
Yes, if you think that it's all, yes. In my practice, I usually use the retroflexion.
That works.
And
Yes.
rectum.
It's okay. So, yeah, retroflexion is very good, but sometimes it can cause perforation. Very rarely, but I have seen somebody to cause a perforation during the retroflex view. And yeah, instead of that, Of course, you can use retroflexion, but instead of that, I inflate air or deflate air frequently. So in order to observe the anal canal, you should suck air like this. If you inflate too much, you cannot see the mucosa very well. If you inflate much air like this, some part of the mucosa will go behind the scope. So inflate and deflate. You should repeat something like this. So with this deflation, you can observe almost all the surface of the rectum,
Okay, thank you,
even
Professor
without
Kashida.
retroflexion.
Thank you, Professor Kashida, for your presentation.